There are so many myths that have been flying around about neonatal blood pressure for several years. We covered 4 of those myths in the first video, and this is kind of part 2. We'll be covering 5 more myths about neonatal blood pressures. Hopefully, they'll give you a really good understanding of where we are now with how we should be thinking about blood pressures and then treating them if they need treatment. I'm Dr. Tala, and I've been a neonatologist for over 15 years now. I'm also post-call today, so I'm sorry if I trail off a bit sometimes. Okay, myth number 5. Remember, we did myths 1 to 4 in part 1 of this video, so go watch that if you haven't seen it yet. But myth number 5. Non-invasive blood pressure cuffs are excellent at measuring the baby's true blood pressure. The golden standard for actually measuring blood pressures would be the intra-arterial axis, so a UAC or a PAL. As you all know, we all try to get central lines out as quickly as possible, so we get UACs out when we can, and we don't love putting the PALs in, and we're definitely doing it less and less. We get very worried with the peripheral arterial lines that it will affect the perfusion to the digits. So we've all seen babies lose the end of fingers and toes because they had a PAL in, especially in situations where you have decreased perfusion anyway. So obviously we come to rely on non-invasive blood pressure monitoring a lot more. But how accurate is that non-invasive or like the cuff blood pressure monitoring? A study was done in Australia in babies less than 32 weeks, and they compared 1,800 measurements of a non-invasive or a cuff pressure monitoring with the intra-arterial monitoring to see how they kind of compared. These are the results that they got. So if you look at this graph, the x-axis shows what the blood pressure was according to the UAC. So kind of the true gold standard blood pressure is what we assume with the UAC. The y-axis shows how much higher or lower they found the blood pressure based on cuff pressures. Sometimes they're great, as you can see by all the dots around 0, but sometimes they're really bad, more than 20 below or above the actual real blood pressure. So the authors of this study concluded that if you're actually going to be doing something about the blood pressure, you should probably be getting an intra-arterial sample. The International Neonatal Consortium published a review article a few years ago where they analyzed and kind of did a literature search on the evaluation of blood pressures with non-invasive means. In this article, they talk about all the different ways that blood pressure can be affected anyway. Obviously, if the baby is screaming its head off, the blood pressure is going to be higher than if the baby is fast asleep. They also talked about the importance of the right cuff when they're measuring the blood pressure in babies. Based on their literature review, they concluded that the mean blood pressure, when it's measured non-invasively, is probably the one that correlates the closest with the actual blood pressure. So the mean blood pressure is a lot more accurate than either the systolic or the diastolic blood pressure. They also recommended that unless there's a contraindication, we should always be using the right arm to non-invasively measure blood pressures. They did say in the first few days of life that we can measure the blood pressure on the legs. There is also a whole world of data about having the wrong cuff size can really affect the accuracy of the blood pressure. And obviously in babies that can go all the way from like 400 grams to like 5 kilos, it's very easy to get the wrong cuff size to measure babies' blood pressures. In their review article, they cited several papers that showed that the most accurate blood pressure could be obtained by using the width of the bladder. So this is the length, this is the width of the bladder. It should be about 50% of the circumference of the baby's arm. So actually, this blood pressure cuff is absolutely perfect for this little mannequin. So it takes up about 50% of the baby's circumference of its arm. So let's rewrite that myth. The mean blood pressure taken in the right upper extremity by a correctly sized cuff is going to be your most accurate non-invasive blood pressure measurement. However, there is wide variation in accuracy, so if you really are worried about blood pressures, then take this into account. Myth number 6, we should treat all low blood pressures the same way. Okay, if you've been listening this far, then you know perfectly well that this isn't true, because there are lots of different reasons why you might end up with a low blood pressure. For a long time, our standard approach to treating low blood pressures would be to give a fluid bolus and then start dopamine, and then titrate up the dopamine until you got the blood pressure that you wanted. And we do this pretty much no matter what the cause of the hypertension was. Obviously, that's not strictly true. If a baby had a hematocrit of 17 and low blood pressures, we'd give blood. If a baby had a tension pneumothorax and low blood pressures, then we would put in a chest tube. So already you're realizing that there are many different causes of low blood pressures, and so we should figure out exactly what's going on and treat that. And using examples that we already gave in the first video, you can see how just giving fluid and starting dopamine isn't always the right thing to do. So for example, the baby with the PDA, the heart is pumping okay, initially at least, but there is fluid runoff. We probably don't want to give a fluid bolus because if anything, more fluid is going to end up in the lungs. Or what about the baby with HIE whose heart isn't pumping well? Giving more fluid here may actually make the heart fail. We don't want to overload the heart even more. What this heart really needs is more help with actually pumping. So always giving fluid isn't necessarily going to be the right answer. So as you've probably figured out, since so much of the blood pressure is actually dependent on the cardiac output, that seeing what the heart is actually doing could help us figure out what's causing the low blood pressure and therefore help us treat it. So by getting an ultrasound or an echo of the heart, there are many things that we could find out. For example, is the heart squeezing hard enough, or is it like feebly squeezing? Is the heart having to push against really high pressures? If that's the case, if anything, maybe we need to lower the vascular resistance. Maybe we need to lower the diastolic blood pressure to help the heart squeeze harder. Is there an anatomical issue with the heart that's causing us to end up with decreased oxygenation? Is there a large PDA? Is the heart well filled, or is it like barely getting any blood actually going back to the heart? Do we need more fluid or blood so that the heart is able to pump more around the body? So you can see all the different ways that getting an ultrasound of the heart could really help you in figuring out what is actually causing the hypertension. And so this will give us a much more directed approach to how to treat these babies. And we'll be talking about that more in the last video. So to rewrite myth number 6, we should not be treating all blood pressures the same way, and getting a bedside echo or an ultrasound of the heart could really help us determine exactly how we should be treating babies. Myth number 7, always start treatment for hypertension with a volume bolus. Okay, we already kind of covered this a little bit in myth number 6. We all do this a lot in the NICU. We have a borderline or a low blood pressure and we'll give 10 mLs per kilo of crystalloid, or we'll give a blood transfusion, say 15 mLs per kilo. Obviously, if this is an issue where volume loss was thought to be the cause of the hypertension, then this is a super reasonable thing to do. So if the baby lost blood, had a large bleed or a large IVH, or the baby's been urinating like a racehorse for the last 24 hours, then yes, we should replace that fluid or blood as necessary. Another situation where volume could be very helpful is in sepsis or NEC, where all the peripheral blood vessels have really vasodilated and you just kind of have to fill up a lot more of those blood vessels. Or those blood vessels could be really leaky as well, so a lot of the fluid is actually leaking out of the capillaries. Then yes, those babies often do need fluid resuscitation. But if there's no history of fluid or blood loss or third spacing, where the blood is kind of leaking out of the capillaries into different spaces in the body, then really giving fluid resuscitation doesn't help. And in the last myth, we talked about the PDA baby or the HIE baby, where fluid might even make things worse. Also, and this is important, that it's been shown in studies that giving fluid boluses, even if it does increase the blood pressure a little bit, does not improve the blood flow to the brain. And ultimately, that's really what we're trying to do. Very importantly, make sure that the brain is getting all the blood that it needs. So even in these situations, fluid resuscitation isn't necessarily helpful. And we also know that giving a lot of extra fluid to babies is not good for their general outcomes. It increases PDAs, it increases NEC, and it even increases mortality. So I know that you all know this, but in older children and in adults, we would casually give many fluid boluses and then start on a pressor. We're talking 20, 40, 60 mLs per kilo. That is definitely not something that we would want to do in a premature infant. Let's rewrite that myth. Give a blood transfusion or a fluid bolus for situations that are suggestive of blood loss or fluid loss, or for a septic shock, third spacing neck type situation. In all other situations, you can give a small fluid bolus, like 10 mLs per kilo, while you're trying to decide what to do next. Avoid excess fluid administration though. Myth 8. The first medication you should use for low blood pressures is always dopamine. We've all done this for a really long time. And the thing about dopamine is that it's such a kind of blanket drug. It can have many different functions on the heart and the vascular beds at different doses. So we can kind of see how it got this kind of superhero type status in the NICU. So let's just talk about dopamine for a second. Dopamine is an adrenergic agent, which means that it stimulates adrenergic receptors, which is the alpha and the beta receptors. I don't want to get too bogged down in these. We're going to talk a little bit more about them in the next video. And approximately 25% of the dopamine that gets infused into the body gets converted into norepinephrine. And norepinephrine is a strong alpha adrenergic agent. So norepinephrine is a strong vasopressor. Dopamine can stimulate alpha, beta, as well as its own dopaminergic receptors. But what's interesting is that it's difficult to know exactly how much these receptors are going to be stimulated in any individual baby. The way we classically use dopamine is that at low doses, so less than or equal to 3 mics per kilo per minute, then mostly the dopaminergic receptors are being stimulated. And so what these do is they increase renal and splanchnic perfusion. So this is where we're giving dopamine at the renal doses, hoping that the baby's gonna pee. At slightly higher doses, it mostly works on the heart, so more of like the beta adrenergic receptors. And then even at higher doses, it has more of a vasopressor effect. So mostly working at like the alpha adrenergic receptors. If this all happened at exactly the same dosages, then we could titrate dopamine so easily. At up to 3 mics per kilo, we could use it for renal perfusion. At like 3 to 6 mics per kilo, we could use it for its inotropy effect, so like to squeeze the heart harder. And then maybe above 6 to 8 mics per kilo, we could use it as a vasopressor, so squeezing those blood vessels to increase the diastolic blood pressure. But unfortunately, there are several problems with dopamine, and I'm going to list them now. The first problem is that all this data on the dopamine dosages and the pharmacokinetics and everything came from adults, and it really hasn't been proven in infants, let alone premature infants. And we know that in infants, the different dopamine dosages can affect each infant slightly differently. So the heart squeezing effect and the blood pressure squeezing effect might happen at completely different dosages for 2 different babies. That's a problem. The second concern is that we've seen that in animal models, high levels of dopamine can cause arrhythmias. Again, we don't really know exactly at what level in babies that the babies are going to be predisposed to arrhythmias, and it's going to be very different from one baby to another. The third concern about dopamine is that in addition to its vasopressive effect, so squeezing the arterioles and increasing the diastolic blood pressure, it can very often increase the pulmonary vascular resistance as well. So for example, if you have a baby with PPHN or you're worried about the lungs in some way, then the dopamine is probably going to make that work. The fourth thing is, and I'm just saying this so that you're aware of it, dopamine can affect thyroid stimulation hormone production as well as the actual levels of thyroid hormone. So if you're on high doses of dopamine for a long time, just consider that. And the fifth thing, as if all of that wasn't enough, dopamine can directly affect the baby's ability for cerebral autoregulation. So cerebral autoregulation is this process where the blood vessels in the brain will either constrict or dilate to make sure that they're always getting exactly the right amount of blood flow going to the brain. So for example, if the blood pressure goes down in the body, then the cerebral vessels will dilate to make sure that more blood is going to the brain. If the blood pressure is really high, then the cerebral vessels will constrict, again, to make sure that the cerebral vessels aren't necessarily seeing that high blood pressure, but they're still getting the flow that they need. So if dopamine is going to ruin cerebral autoregulation, then for example, even if you have a really high blood pressure, then those vessels might still be dilated. And so the brain is much more likely to get gushes of blood coming up and more likely to get a hemorrhagic stroke or something. So based on a lot of these factors, as well as the uncertainty at where the dosages are actually working in each baby, a lot of experts are recommending that we move away from dopamine as a first-line agent in babies with low blood pressure. So to reword myth number 8, instead of starting all babies on dopamine, decide exactly which effect you want from that medication and use a more appropriate medication. We'll talk about this more in the next video. And myth number 9, steroids are bad for premature infants, and so we should avoid using them in the treatment of hypertension. I know this myth is a little weak. I know that we all avoid using them, but unfortunately, when we're all desperate, we all end up starting steroids. But let's talk about it more anyway. So we know that steroids are actually really good at raising blood pressure. In fact, when we're giving steroids for other reasons, we tell family members that one of the things that we're worried about is that it's going to raise blood pressures. So both hydrocortisone, which is a mineralocorticoid and a glucocorticoid, as well as dexamethasone, which is just a glucocorticoid, are both very effective at raising blood pressures. Hydrocortisone has been shown to increase blood pressures in infants with refractory hypertension, so hypertension that's like really not responding to anything else, about 2 to 6 hours after it's first administered. Hydrocortisone works in multiple different ways, or it's thought to work in multiple different ways to actually improve blood pressures. One of the things it does is it increases the number of alpha adrenergic receptors. So it basically makes all the circulating vasopressors a lot more effective in actually raising the blood pressures. Hydrocortisone is also thought to increase production and release of the endogenous catecholamines. So the catecholamines like epinephrine and norepinephrine that we have in our bodies. It's also thought to work in a whole bunch of different ways, but one of the ways that we think about often is that steroids are thought to decrease the capillary leak. So for example, in NEC or in sepsis, if all the capillaries are like really leaky and all the fluids are just kind of leaking out of those blood vessels, then just giving steroids makes the fluid more likely to actually stay in the blood vessel, hoping that it's probably going to help the diastolic blood pressure. Also remember that babies have a relative cortisol deficiency, especially premature babies. So even if when they're just feeding, growing, even if that doesn't kind of affect them, generally when we all get sick, our steroids go up. So in a lot of preemie babies, when they get sick, they don't have the ability to actually increase their endogenous, their own steroid production. So they have a relative deficiency. This is especially true if their adrenal gland took a hit. So maybe they had a bad hypoxic hit or there was a bleed into the adrenal gland. By definition, this is going to affect the adrenal gland's ability to produce those stress steroids. I can't finish this segment without actually saying this. I know that you all know it, and we all know it from the literature that came out in the 1990s and the 2000s. And that is that we know that giving babies a lot of steroids, high doses for a long period of time, is not good for neurodevelopmental outcomes. So we shouldn't immediately jump to using steroids. However, if a baby is showing clear signs of adrenal insufficiency, and by the way, we're seeing this more and more now in the tiny babies we're resuscitating, the 22, 23 weekers. So for example, the baby's sodium went down, the potassium went up, the creatinine went up, we have decreased urine output, we have low blood pressures, then obviously you should be considering using hydrocortisone in those situations. Also, if the baby has refractory hypertension, so really low blood pressures, baby's not getting the oxygen that it needs, and you're on 1 or 2 or 3 pressors, then obviously at that point you should consider starting steroids as well. So to rewrite that myth, use steroids when you have obvious adrenal insufficiency or when you have refractive hypertension. What we often use is hydrocortisone And we start 1 milligram per kilogram Q8 hours. If you're really desperate, you can give kind of a bolus dose of 2 mg per kg right at the beginning. And those were our 9 myths. Next, go watch how we treat different specific scenarios in the NICU. But if you reach this far, please like this video, tell us where you're watching from, and again, I want to thank you so much for being here. Bye.